guys. 2 more days to go for INICT November 2025. I hope your preparation is going well, and all the others, I hope whatever you're preparing for, you're being productive through the day. And today's Telegram quiz was about Uvea, Retina, and Glaucoma. Let's start with the questions, shall we? Shall we wait for a few more students to join? Okay, we'll start with the first question. So the first question is, which of the following is a cause of panuveitis? Now, what is panuveitis? Panuveitis when all the uveal tract components are inflamed. So what are the uveal tract components? Iris, ciliary body, and choroid. When all the three are affected at the same time, that is panuveitis. Okay. So first one is lens-induced uveitis. See, lens-induced uveitis is a granulomatous anterior uveitis because lens is an anterior segment structure and this is a purely anterior uveitis. So that's not the answer. Fuchs uveitis syndrome. Fuchs uveitis syndrome is actually the Fuchs heterochromic iridocyclitis. So it is iridocyclitis. So predominantly it is an anterior uveitis, but in some cases when you do have a little bit of vitritis, maybe we could say there is intermediate uveitis also, but it is definitely not a panuveitis. Okay, Fuchs uveitis syndrome, that is the Fuchs heterochromic iridocyclitis, that is definitely not a panuveitis. Okay, so it is an anterior uveitis and it is a non-granulomatous anterior uveitis. Now Behçet's uveitis. Behçet's uveitis is a panuveitis. Okay, Behçet's uveitis is a non-granulomatous panuveitis. Note it down. So first I told you lens-induced uveitis is a granulomatous anterior uveitis. The second option was Fuchs uveitis. Fuchs uveitis is a non-granulomatous anterior uveitis and Behçet's is a non-granulomatous panuveitis. Okay. And HLA B27 associated uveitis, all these arthritis associated uveitis, they're all anterior uveitis. Okay, now anterior, and most of them are non-granulomatous. There are some HLA associated, not B27, others HLA associated, like if you say even Vox-Koyanagi is associated with HLA component, it is granulomatous. So just because it is HLA, it is not, you can't say it is granulomatous or non-granulomatous. Hello, who's that? Kritesh. Hi, Kritesh. All right. Shall we move on to the second question? So have you learned something from the first question? Give me a thumbs up if you learned something from the first question or something. You've learned actually 4-5 things, lot of MCQs. Okay, अगर मैं गिनने पे पढ़ूंगी तो 10-12 तो निकल जाएंगे, ठीक है? तो let's go to the second question. Which of the following retinal vasculitis is primarily a phlebitis? See, first of all, now this retinal vasculitis is a part of posterior uveitis. So when I say posterior uveitis, it could be a purely choroiditis, chorioretinitis, retinochoroiditis, peripheral retinal vasculitis, neuroretinitis. All these come under posterior uveitis. What are these 5 components under posterior uveitis? Repeat after me. Choroiditis, chorioretinitis, retinochoroiditis, peripheral retinal vasculitis, so inflammation of the retinal veins, and neuroretinitis. So that is your RNFL inflammation. Hi, yeah, five components under posterior uveitis. So now going to the question, which of the following retinal vasculitis is primarily a phlebitis? Phlebitis means inflammation of the veins. So let's go to the options. Vogt-Koyanagi-Harada syndrome, it's not a retinal vasculitis. Eales disease, yes. What is Eales disease? It is a inflammation around the peripheral retinal veins. Yes, so that is a phlebitis, especially of the peripheral retinal veins. It is a phlebitis. So Eales disease, that is the answer. Also sarcoidosis, although it is not among the options, sarcoidosis also is primarily a phlebitis. Okay. Now toxoplasmosis is primarily an arteritis, or it affects the arterioles. Yes, it affects the arterioles. Then Fuchs uveitis, it's not retinal, it doesn't involve retinal vasculitis at all, so it is a falto option here. Alright, question number 3. All of the following uveitis are of sudden onset except. So probably we are looking at something which is a chronic uveitis, okay, because always acute uveitis are always sudden in onset, acute presentations. So endophthalmitis, yes, endophthalmitis we know is an ophthalmic emergency, sudden onset of pain, redness and decrease in vision. So that is classic endophthalmitis. So that is not the answer, because we are asking for which is not a sudden onset of uveitis. Posner-Schlossman syndrome, again you got this sudden onset of blurring of vision, patient has pain but a relatively white eye, dilated pupil. Posner-Schlossman syndrome, when it presents, although the underlying thing is a chronic anterior uveitis with trabeculitis, but the presentation, it's a glaucomatocyclitic crisis. It results in a crisis, right? So it is sudden in onset. So remember the other name of Posner-Schlossman syndrome. You don't have to be in two minds at all about this question, okay, or about this option. So that option is ruled out. What is the third option? HLA-B27 uveitis. HLA-B27 uveitis are all acute. So anything acute is sudden onset. So again, that is ruled out. Fuchs heterochromic iridocyclitis, patient doesn't even know this. Patient 40 years old, usually a female, and this is unilateral, it's very chronic, low grade, there's no redness, nothing. Patient doesn't know. Patient knows it only when they develop complications like a cataract. So the patient comes to you with unilateral cataract and you're seeing this 40-ish. You feel like, okay, it's not really the age for cataract, and then you see there's a posterior subcapsular cataract. Then you look at these keratic precipitates which are all over, distributed all over the cornea, the stellate KPs. So Fuchs heterochromic iridocyclitis is chronic. So it is not sudden in onset, it's very, very insidious in onset. So the answer to this question is Fuchs heterochromic iridocyclitis. Have you understood this, Bache? If you understood this question, give me a thumbs up. Let's go to the next question. Now the next question is actually an image. Very beautiful image, nothing much. They've just said it's a 55-year-old male patient whose fundus image is given, and this is a fundus image. Okay, pretty straightforward, this fundus image. You're seeing a lot of dot blot hemorrhages, all these red ones, very, very small ones are the microaneurysms, a little bigger one are all the dot blot hemorrhages. Then you see these yellow lesions which are all hard exudates. So you see a mixture of red and yellow dots, nothing more than that. There's no bleeding, or you don't see any new vessel. New vessels will look like, laces. Yes, very good, Kapil. It's NPDR, non-proliferative diabetic retinopathy. Okay. Now, people don't worry about anything fundus. No, see, sickle cell retinopathy, the first option. See, sickle cell retinopathy, first of all, the findings will be in the peripheral retina, not in the central retina like this image. This image you're seeing the optic disc and the macula. This is the central retina. Central retina mein you don't have findings in sickle cell retinopathy. It's usually in the periphery, and in the periphery you will have CFAN neovascularization. I'll teach you that on another day. Okay. So it is definitely not sickle cell. Retinitis pigmentosa, you got those calapuchis, na? You got these black insects from the periphery crawling in. There's nothing black here at all. See, always I tell you retinitis pigmentosa, you remember the calapuchi. Let the calapuchi echo for you in the exam also. It's crawling in from the periphery. What is this calapuchi? These black insects. Black insect-like stuff. That is your degenerated rods, and in that area there are these black bone-like corpuscles. So those are there in the periphery. Okay, so picture will be a little wider, and you'll see the black ones which are not seen here. So this is definitely not retinitis pigmentosa. Central retinal vein occlusion. But central retinal vein occlusion, you will see this splash tomato appearance like this. So much of retinal hemorrhages in all the quadrants, and probably even the disc which is edematous. So can you see the blurred margins of the disc? There is disc edema, and you might see a few cotton wool spots in this picture. Cotton wool spots are actually in between the hemorrhages. You're not seeing it very well. So you'll see a splash tomato appearance. So definitely not CRVO. Okay. So this is definitely not CRVO. See, you just get a combination of red and yellow dots. Is that clear? Are you fine with NPDR and CRVO in just a span of 10-20 seconds? You got it right. Okay. So it is definitely not CRVO. Is there any other option? I think that's the fourth option is our answer, which is non-proliferative diabetic retinopathy. All right. Yes, good, Kapil. So you get the bony spicules in retinitis pigmentosa. Okay. So we'll move on to the next question. All of the following are true regarding rhegmatogenous retinal detachment except. So we need to find out the false statement. See, rhegmatogenous retinal detachment means that which develops after a retinal tear. Okay, regma means a tear. So after a retinal tear or 1 second. So option A, detached retina is convex and irregular. See, the retina which is detached, okay, from the RPE, the neurosensory retina that is detached, it is convex and a little wavy. So it is irregular and it can move, it's mobile. When you move the eye, when you see on B scan, there will be mobility as well. Is that clear? Alright, so this is about rhegmatogenous RD configuration. If you see serous RD, remember serous RD like a bulla. If you have a bulla, how will it be? Convex and smooth, not irregular. Convex and smooth. Hamara rhegmatogenous is convex and irregular. Okay. Whereas serous would be convex and smooth. Tractional would be concave. Okay, and fixed because of the traction bands in the vitreous. Is that, can you imagine this? You just imagine this. You don't have to mug it up at all. As I say, you can just imagine it. So option A is true. We are asking for the false statement. Tobacco dusting of vitreous, yes, which is present. That is the Schaffer sign, right? Tobacco dusting in the vitreous, which is present exclusively in rhegmatogenous RD. Yeah. Alright. May occur if HSV posterior uveitis is not treated. Yes. When you have these herpetic retinitis, it leaves the retina very, very thin. So between the affected retina and the normal retina, at the junction, at the border especially, you'll get these retinal holes and retinal tears because the retina is thinned out after a herpetic infection. So if you don't treat it on time and if you don't treat it with the proper regimen, then the patient can have a rhegmatogenous retinal detachment. These herpetic infections. Yeah. Are you trying to type something and I'm not able to see it? Okay. So that again is true. Fibrous bands are seen in the vitreous. Just like I told you, fibrous bands in the vitreous are seen in tractional RD. We're talking about rhegmatogenous RD. So that's a false statement, which is our answer. Okay. So option D is our answer for this particular question. Okay. We'll move to the next question. Which of the following investigations is useful to identify macular ischemia? See, traditionally, when I was a student, the answer for this was straight away fundus fluorescein angiography. Okay, but nowadays, first of all, FFA is done very, very less. We don't want to do any kind of invasive procedure for the patient. But now when I look at it, because if I've been doing older Q banks, in my mind it would be only FFA. But in the options, among the options, there is no FFA. OCT is there. See, OCT, you can see all the layers of the retina, the layers of the choroid, you can see the posterior vitreous, you can see the foveal contour, all that beautifully you can see, you can measure all these layers ka thickness on OCT. Yeah, that was also a previous INI-CT question. Which are the following investigations to look at the various layers of the retina. In fact, even the layers of the choroid you can see on OCT. But here my question is about macular ischemia. See, macular ischemia I can't make out on OCT. Either on FFA or OCT angiography. Yeah, Octa. On Octa, we can actually visualize the density of the various vascular layers. See, in the retina, you have two vascular plexuses, the superficial capillary plexus and the deep capillary plexus. You can visualize them. You can see the density, if there's any dropout. And you can even see up to the choriocapillaries. Okay, so the superficial capillary which is there in this RNFL ganglion cell layer junction. Then you can see the deep capillary plexus which is in the ONL, that is the outer nuclear layer, and you can see up to the choriocapillaries. So all these vessels can be seen, and therefore at the macular area you can see if there is any dropout. So if there are capillary dropouts, you know there is macular ischemia, okay, ischemic maculopathy. So Octa is your answer. Fundus autofluorescence, guys. Fundus autofluorescence is for seeing any problem of the RPE essentially, because RPE contains lipofuscin. So if I have too much of lipofuscin, or if I have an less lipofuscin, in the sense when my RPE is atrophied. So for those conditions, I want to look at fundus autofluorescence, okay, not for macular ischemia. Pattern ERG. See, pattern ERG is you show a pattern to the patient, like a checkerboard pattern. You alternate it. The black and white squares will alternate, okay, and that will flash the electroretinogram. Okay, so this is a specialized type of electroretinogram. Pattern ERG, one MCQ. Okay, it is used to differentiate whether the patient is having a macular disease or an optic nerve disease. See, simply I can find out if by RAPD I can find out, but to be very, very specific, pattern ERG is a function of the retinal ganglion cells, to be very specific, because when you talk about your routine ERG, ganglion cell has no contribution to it. The A wave, B wave, C wave. Na? A wave is from photoreceptors, B wave is from, initially from Muller cell, representing bipolar cell activity. C is from photoreceptors. Some of you are feeling like ma'am is going on, very good Kapil, I didn't see your message, but OCT angio, very good. Ma'am is going on Rajdhani speed, or I don't know, Tejas speed. But I want to, put in a lot of information within this module. So what was I saying? So ERG, the A, B, C waves, nowhere ganglion cell. But if you're talking about pattern ERG can measure, or it can find out if the retinal ganglion cell is functioning. Okay, so it's got nothing to do with the vascularity or macular ischemia. All right, now let's go to the glaucoma question. All right, which of the following is or are the mechanism of actions of ripasudil? Now, what is ripasudil? Ripasudil is an anti-glaucoma drug. What class of drugs, guys? It is Rho kinase inhibitors. Yeah. Now, these Rho kinase inhibitors have three mechanism of actions by which they decrease intraocular pressure. One is, first of all, they decrease the IOP, the aqueous production. Yeah. Primarily, they act by increasing trabecular outflow, yeah, and also they decrease the episcleral venous pressure. See, when the episcleral venous pressure, the episcleral veins are outside the eyeball. So when that pressure goes down, obviously the pressure inside the eye, the IOP which is high, there's a pressure gradient, the aqueous can easily come out. That is the funda of this. So decrease episcleral venous pressure. So the answer is going to be a combination of I've given it as, you choose 1, 2, 3. So ripasudil, netarsudil, these are your Rho kinase inhibitors with mechanism of action decreasing aqueous production, increasing the trabecular aqueous outflow, and decreasing episcleral venous pressure. Is that clear? All right. Now we move to the next question. Which of the following is a direct gonioscope? Again, it's based on a previous year question. So direct gonioscope's prototype is Copy. Okay, Copy, I'm wondering what is the pronunciation of this Copy. Is it Copy or something else? Anyone knows, please ping me, okay? Because I always am sensitive to this pronunciation. Which one, beta? Yeah, Kapil, it is useful, right? Rho kinase inhibitors, they promote endothelial proliferation. So it is useful, especially in case of Fuchs endothelial dystrophy, bullous keratopathy for any reason. When you have an endothelial dysfunction and you want the endothelium to proliferate and migrate, the Rho kinase inhibitors are useful. So that is another function. I posted this in my Instagram handle a couple of months ago. So maybe I'll share that with you here. Okay. So now, going back to our question, direct gonioscope. See, Copy is the prototype direct gonioscope. See, direct gonioscopes use prisms, okay, whereas your indirect gonioscopes use mirrors. Now, you have Copy as a direct gonioscope, then Swan-Jacob, which is one of the options I had given in the question. So, Swan-Jacob especially is used for children. Yeah, especially in children, Swan-Jacob is useful. Then there's something called Richardson-Schaffer. Then there is Leiden, Layden, Leiden. N number of direct gonioscopes. But at least you should remember three things. Okay, Copy you should definitely remember. Swan-Jacob you have to remember. Then Barkin. See, Barkin, no? Barkin's membrane, that. Dicey membrane that only Barkin ever saw in congenital glaucoma. So because that is in congenital glaucoma and in kids you need a direct gonioscope. So because you need to operate on them, right? So you have to remember this Barkin's. Then as I said, even laden especially for preterm kids. For preterm kids, if you want to operate, then it is laden. So these are all direct gonioscopes. Now what about indirect gonioscopes? Hamara Goldman, 1 mirror, 2 mirror, 3 mirror, all Goldman are indirect. Then Posner 4 mirror, Sussman 4 mirror, Zeiss 4 mirror. Then your trabeculoplasty lens. Okay, your rich trabeculoplasty lens is an indirect gonioscope. All right. It's keep. All right. Thank you, Kapil. I've always wondered because only yesterday I was watching a video and somebody said keep. I was like, all these decades, I've never heard of this pronunciation, neither by my professors nor any colleague. And I've been teaching thousands of students copy. So it's keep. So keep nodules. So keep nodules are the pupillary border. All right. Thank you, Kapil. All right. So which of the following is a direct gonioscope? Goldman? No. Goldman is indirect. Posner? Indirect. Swan-Jacob? Yes. For children, we use Swan-Jacob. It is a direct gonioscope. Zeiss 4 mirror. It's an indirect gonioscope. Zeiss is an indirect gonioscope. Okay. Moving on to the next question. Periocular hyperpigmentation. So periocular hyperpigmentation is a complication of your prostaglandin analogs latanoprost. So that's why you be very careful if you're giving unilaterally, because one side, see, if you have black circles both sides, it's still okay, right? But one side, if you have, it's really not okay. So periocular hyperpigmentation is a complication of prostaglandin analogs. So the option that I had given here was latanoprost, which is correct. Now, what is the complication that you get with netarsudil? With netarsudil, the most common complication is conjunctival redness. But the characteristic complication that you get is cornea verticillata. Alright? Okay. Next question. 38-year-old male on latanoprost, HS, OU. Now, what is OU? Both eyes. Okay. HS bedtime, because that is the dosing of what drugs? Latanoprost. That is a prostaglandin analogs. Since the last 6 years, he uses plus 3D sphere glasses. That means he's a hypermetrope. On examination, OU findings, that is both eye findings, patent peripheral iridotomy. So that gives me an idea. A hypermetrope who has previously undergone peripheral iridotomy, which means something to do with angle closure glaucoma. Now, you should not get carried away by latanoprost. See, latanoprost, I've always told you, it is a drug of choice for both primary angle closure and primary open angle, because it decreases IOP fantastically, 33% from baseline IOP, which is like fantastic, okay, and a very relatively low side effects profile. The only inhibition is cost inhibition, okay, otherwise a fantastic drug. So patient 6 years has been on latanoprost, both eyes, and patent iridotomy, and 3D means plus 3D sphere glasses, hypermetrope. So something is telling me, hey, we are dealing with an angle closure patient, maybe. Okay, and then they tell us 270 degrees peripheral anterior synechiae. What is peripheral anterior synechiae? Your iris sticking to the cornea. So when your iris is sticking to the cornea, obviously when you're doing gonioscopy, you can't see the angle, right? And 270 degrees means 3 quadrants. So 3 quadrants you have peripheral anterior synechiae, and the IOP they say is 32 millimeter mercury, which is high. Fundus is normal. Perimetry is normal, meaning now we are dealing with a glaucoma patient. Looks like everything is pointing towards that. Fundus is normal means optic disc is normal. There are no optic disc changes of glaucoma. Perimetry is normal means visual field defects are not there. Yeah. So that means the criteria for glaucoma is not fulfilled. See, criteria for glaucoma 3. 1 is your optic disc changes, characteristic optic disc changes, then visual field defects, and RNFL thinning when you see on fundus or OCT. Yeah, on OCT. So these are the 3 criteria for diagnosis of glaucoma, which the patient is not fulfilling. But he is definitely, according to the classification, he is primary angle closure, because he's got IOP increased, he's got his angle closed 3 quadrants or more. 273 out of 360 degrees, 270 degrees means 3 quadrants, no? 3 quadrants is closed, angle closure glaucoma. Okay, let's see. Option A, primary open angle glaucoma. No, yeah, when you have peripheral anterior synechiae 270 degrees, Definitely not. It's not an open angle glaucoma. That day, previous session, somebody asked, ma'am, explain between primary open angle and angle closure. This is angle closure. Okay. When you have peripheral anterior synechiae, when you have iris bombay, all these are angle closure. So this is not primary open angle glaucoma. Primary angle closure suspect. See, when you have when you talk about suspect, PSCS may it's just the touching. Okay, so you may have peripheral anterior synechiae, or you may just have apposition, you know, like you're sitting with your boyfriend and you're just nudging each other. You are not engaged, you're not committed. Okay, it's just a suspect. I'm just suspecting because it is constant public display of affection, PDA. I suspect something is there. Okay, so peripheral angle closure suspect is when you only have ITC, iridotrabecular contact, not a permanent closure. And definitely intraocular pressure is not high, because when you're dating with only PDA, no commitment, nothing, it's nice, no, there's no pressure on you, nothing, no pressure on you at all. So the IOP is normal, but now a patient IOP is high, so it is not PACS. It's gone to committed stage because IOP is high and peripheral anterior synechiae is there. Okay, so when the IOP is high but permanent damage not done, that means you're not married. If you're married, then permanent damage. Okay, so I'm not against the institution of marriage, I'm just saying. Okay, so when Shadi is on bus, bichara, your Fadgaya, IOP is high, visual field defects are there, optic disc changes are there, then on OCT also you will see RNFL thinning everywhere, hair gone, everything gone, life is gone. So that is PACG glaucoma. But this bacha or this patient, 38-year-old Buddha, has not got fundus changes nor perimetry, visual field changes. So he is only primary angle closure. He is neither in the suspect stage nor in the glaucoma stage. ये in between का है PAC. Okay, primary angle closure. That is a diagnosis for this patient. All right. So that is it for today. Any other questions? Kapil, what have you typed PACD? What is PACD, beta? Okay, any other questions or doubts that you want me to clear? And when you have an angle closure attack, that would be APAC, okay, acute primary angle closure. That would be the diagnosis, or you can call it acute congestive glaucoma. That was an older term. Oh, it was a typo. All right. Okay. But you understood, know what is PACS, what is PAC, and what is PACG, and what is POAG? Yes, everyone? Do you have any other doubts? Guys, come on, if you have any doubts, just put it here. Hi, ma'am, I'm new here. All right, Narsimha, Vasanta. Good. Welcome. we love new students. I hope you've been there from the start of the session. If you joined just now, please watch the session again. It will be very high yielding. Whichever stage of preparation you are in, you'll definitely fall in love with Ophthal. That much I can guarantee you. How much is atropine effective in preventing myopia? Dr. Kotari, this is not a refraction session. I guess refraction sessions tomorrow or day after. Probably I would explain it that day. Can you be patient and join us at 8 p.m. on that day? Let me just check which is the day we are having refraction. Just a second. Give me a second. Because I normally refrain from mixing other topics on the day, because then students will get into this habit of, you know, badgering me with all sorts of questions. Yeah, refraction is on 8th November, doctor. So 8th November, 8 p.m. your atropine ka question can I answer? And actually atropine, I've actually posted a video. I'll post the link of the video in the comments. You can watch it. I've already actually described atropine and the studies where we use low dose atropine and all. I've explained it very thoroughly with all the dosing, the concentrations, how it acts, all the mechanisms. So if you can watch that video, well and good. At the end of the session, I will post a link of it in the comments. And again, I will take up this question on the 8th of November. I'll remember this, I'll note it down, and I will explain this for sure, Dr. Kotari. Thank you for your patience. And someone else, I think 2 days ago or a day ago, they asked about, ma'am, please explain POAG and PACG. We've almost done it here. Yeah. Any other questions pertaining to uvea, glaucoma, and retina? See, today again I posted about vitamin A deficiency retinopathy on my Facebook page. Okay, everything goes by the same name, EyeMentor Dr. Rajarathna. So you can check my official page where we post only Ophthal stuff or some motivation stuff. So where I have posted about vitamin A deficiency retinopathy, it's so beautiful. Okay, so if people are interested, go and check out that as well. So I have described the fundus findings, the OCT findings, and your favorite autofluorescence finding as well there. Yes, ma'am, why we keep near vision lenses? Narsimha, see, this is a refraction question that you are asking. I'll definitely answer this question. You copy this question and keep it with you. Can I explain this on the 8th of November when our topic is refraction, squint and lid ocular adnexa. Is it okay? Can you be patient for 2 more days at 8 p.m. At the end of the 10 questions that I discuss on 8th, I will take up this question and Dr. Kotari's question as well. Alright? Because the other day also someone asked, she was also asking some squint related questions. So I told her we'll do it on November 8th when we're doing the squint session. Guys, retina question, glaucoma question, anything? Or shall we wind up? If you don't have any questions regarding uvea, retina or glaucoma, can we wind up the session? Tomorrow's topic would be orbit, trauma and neuro-ophthalmology. Tomorrow's questions. Thank you, Narasimha. Thank you for your patience and understanding. So tomorrow Telegram quiz, guys, on my Telegram academic group, there's a regular quiz every day at 6 p.m. 10 questions, and those are the questions that we're discussing here at 8 p.m. So tomorrow's topic would be orbit, trauma and neuro-ophthalmology. I would welcome all of you to sincerely attend the quiz because questions will come from the discussion, from the quiz, whatever I say. Okay. Of course, doctor, we have to mix now. When the IOP is not coming down after a trial, then we will definitely add different mechanism of drugs. Maybe maximum 2, I do till 3 drugs, not more than that. So yeah, definitely you go for maximum medical therapy, MMT, maximum medical therapy 3. Some people do even 4 drugs because now we have a lot of options too. 4 drugs, and then beyond that, then take up the patient for surgery. Or actually even before that, people would want to go for surgery. Hi Sukhdev. All right. See, the mixed combination would actually depend on what is working for the patient, looking at the safety profile of the drugs for the patient, how much the patient is accepting, tolerance, all that. Based on that, yes, we do a mixed combination because our ultimate aim is to decrease the IOP somehow. Okay, any other questions, guys? Okay, so shall we shut shop? Okay, chalo. Okay, bye. See you tomorrow at 8 p.m. And before that, 2 things. Check out the vitamin A deficiency retinopathy on my Facebook page. That is number 1 reminder for you. Number 2, tomorrow's Telegram quiz. Start preparing. It's orbit, trauma and neuro-ophthalmology. That is at 6 p.m. on my Telegram academic group. And then, what is next? Tomorrow 8 p.m. I will see you here. And also watch out on what if one drug is not effective. If it is not effective, then we have to take it off. Na? It's always a trial and error we match. Yeah. you can't decide on one day. At least you have to give a minimum of 3 to 4 weeks for the drug to act, and then call the patient for follow up, and then it's like a trial and error. Okay, chalo guys, see you tomorrow. Bye bye. I hope there are no more questions coming from you, Dr. Kotari. All right, bye. Good night, guys.